I'm going to give my talk with broad strokes. I'll talk a little bit about some of the specifics, but I know that we want to make sure we maintain time for the questions and answers. So the details, many of the details are in your syllabus, and we'll be happy to comment more on those, but I won't dwell on too much on all the specifics. The real two goals that I wanted to have of my presentation were to talk about the rationale for treatment. Why do we do the things that we try to do? And then put that in the light of the mechanism of action. How are these treatments supposed to be helpful for patients who have eosinophilic GI diseases? The first question is really why treat? Why do we need to do something about these problems? And I think the obvious and most important is that we improve and or resolve those symptoms. And it goes back to the major goal that we've discussed before. We want to make sure that we can maintain for children normal growth and development, and for adults with these problems that we can improve the quality of life so they can interact in a social situation as well as maintain their professional lives. The second important treatment goal is to improve and or normalize tissue. Now, unfortunately, Dr. Putnam needed to leave, but it's an ongoing point of discussion that we should make a part of our discussion and question and answer period, because what defines normalcy? How often do you need to monitor that normalcy is a point that we still discuss often amongst all of us who care for patients with these problems. And then finally, we want to try to prevent complications. How often those complications occur, what they are, and how severe they are still unknown. We know in general that strictures can happen with eosinophilic esophagitis. They may perhaps happen more in our adult patients, but really these are things that need to undergo definition. Is symptomatic remission sufficient? And I take this slide from a group of slides that were developed from an organization called TIGERS, the International GI Eosinophil Researchers. This slide set was compiled by a number of different leaders within the field to give some standard for talks like this to be given. So that's where this slide came from, and I'll give some recognition for that in the end. But so for requiring histological remission, we think that in some basic models of this kind of inflammation that by treating, we may in fact improve the likelihood that we're going to reduce problems with strictures and things like that. Against requiring histological remission is that the obvious, the risk of the procedure, the risk of anesthesia, and to date we don't have true evidence that there is efficacy in preventing complications by installing treatment. This diagram shows the life cycle of an eosinophil. They are born in the bone marrow. Under a number of different signals, they migrate into the bloodstream. They bind to the lining of the bloodstream and then transmigrate through the wall of the bloodstream into tissues that are exposed to the rest of the environment. So the intestinal tract, as we said, is one of the places the eosinophils reside normally. When they go to the esophagus, for unknown reason, that is abnormal. And I point this out to you, and we'll look at this a little bit more closely at the end, but interleukin-5, which has been mentioned previously in Dr. Markwitz's talk, is a key molecule that helps the growth and development of eosinophils and may modulate how they engage in disease. This slide shows some of the functional properties of eosinophils, and we see an eosinophil here that contains a number of different mediators that can be released immediately, or mediators that can be synthesized within the cell and then released upon appropriate stimulation. So eotaxin 3, periostin, IL-5, these are all chemicals and biological products that may be released within the body. Tell an eosinophil to release their granules or to make new chemicals that go on to cause the types of things that we see in the tissue. So we've seen slides of how the epithelium or the lining may get more thickened. We've talked about how eosinophils may interact with the collagen-forming cells. We've discussed how eosinophils may in fact participate in contraction in smooth muscle cells. And we've also talked a little bit about how eosinophils may release products that can increase the vascularity or growth within those areas. So I show this to you because, again, when we think about new treatments, ways that we can impact symptoms in patients, these are areas that we're actively trying to consider to see if we can block some of those important properties. And the challenge really is trying to balance risk and benefits. Well, what kinds of treatments can be used for these diseases? I want to bring up front first to talk about proton pump inhibitors. So these are medications that, in fact, you're very familiar with, I'm sure, such as omeprazole, lansoprazole, medicines that may reduce the amount of acid that's produced. And I show this to you because this is a cell that makes acid. It's called a parietal cell. The cell releases acid up here into the lumen of the stomach. And the way that it does that is that it receives signals on the base of that cell from different hormones or chemicals that tell it needs to make this acid. And so when we think about this, the cell receives signals such as histamine or gastrin, and then this pump on the top secretes acid. Now, when those signals are received, that's the way that this might happen. So if you have histamine receptors that are present here, and if those are blocked, that may decrease the signal for acid to be released. And medicines that work here are those like Tagamet or ranitidine, so they block one of the receptors. The proton pump inhibitors actually kill this pump on the top of the cell, so they stop the cell from making acid completely. Now, when we think about proton pump inhibitors, what are their roles? They're very important in helping us rule out reflux. If we can treat reflux-like symptoms, if they improve over time, then that's a very important role for this medication. It may offer a benefit in some patients who have EOE. And the reason for that is, as we've discussed, there probably is a spectrum of types of symptoms and inflammation. Some patients who may have eosinophilic esophagitis can also have reflux because the esophagus is inflamed. And if that's the case, then antacids may be helpful. But it's important to remember that it's not a primary treatment for eosinophilic esophagitis. The side effects are shown here that include potential infections and bone fractures. We don't know how often that happens, but it certainly doesn't limit our use of those in many patients. This slide shows the algorithm of use of anti-acid medications. If we have a patient who we suspect, because of symptoms, has eosinophilic esophagitis, we'll use proton pump inhibitors to try to reduce those symptoms. If they are not reduced, then we'll perform an upper endoscopy with biopsy, and depending on the numbers of eosinophils that are present, make a diagnosis. If there are low numbers, that it's probably reflux disease. If there are higher numbers, then it would be eosinophilic esophagitis. Now, the next two sets of slides will talk about dietary management and medical management of eosinophilic esophagitis. If we think about dietary management, the rationale for treating is that we can remove food antigens that may spark this response. And you've heard from Dr. Atkins and Dr. Fleischer about allergic diseases. And in one of Dr. Atkins' slides, he showed that esophagus that if there is penetration of an allergen that may activate lymphocytes and induce this response, if we can remove the food allergens, then we may be able to treat this disease. And the real challenge is figuring out what foods may spark this disease. The different types of food elimination diets include using an elemental formula, so a formula in which all proteins have been broken down to amino acids and thus are no longer allergenic. An elimination diet, such as the 6-food elimination diet, which removes the 6 most common food allergens. And then finally, a tailored elimination diet, which is based on the history that's taken from patients, and then allergy testing that helps to refine what those foods might be. So the elemental diet, you You're well familiar with the fact that it's an amino acid-based diet. There is strong evidence to show that this, in fact, does impact inflammation in a number of different studies now, and really one of the first studies that was published on eosinophilic esophagitis showed that between 92 and 98% of children underwent clinical pathological remission. The symptom resolution was relatively quick, in 7 to 10 days, and indeed the histological remission, as far as we know, occurred within 4 to 5 weeks. We don't know how soon that happens because we don't perform endoscopies that frequently. I think the difficulties are well known to you in the sense of adherence that may be difficult because of taste. I think there have been significant advances in trying to improve the taste and improve the ability for patients to drink this formula. It may require additional devices in the sense of delivery. There is a cost factor, and certainly there may be an impact on quality of life in using these types of formulas. There have not been studies to date showing the strict use of elemental formula in adults yet. There have been studies that have been performed in abstract that suggest it may be beneficial in decreasing some of the inflammation, but I think many of the quality of life issues will need to be addressed to date. Now, what about the use of an elimination diet, so the use of 6 foods to treat this, elimination of 6 foods to treat this disease? And in this seminal study by Kagawala and colleagues, they treated a number of patients by excluding the 6 most common allergens, and they showed a 74% of EOE patients indeed were brought into clinical pathological remission. And it was compared to an elemental diet. Indeed, the elemental diet was much better at doing this, but 74% of patients going into remission is fairly significant, and this certainly is a potential alternative. The benefits are that you may be able to bypass allergy testing. It certainly has been effective, not as effective as an elemental, and it may not be as expensive or as exclusive. I think the difficulties are that certainly those 6 most common foods can be difficult to eliminate from the diet. Now, the last form of dietary management is a tailored diet. And again, as Dr. Atkins and Dr. Fleischer have discussed, if you can identify through allergy testing which foods are suspect, then that would actually offer probably the most targeted type of treatment. This has been studied in several different ways. Dr. Spergel's group has looked at 26 patients, identified those food allergens by skin testing as well as patch testing, and showed that 18 of those patients had resolution of symptoms, 6 had partial improvement, the eosinophil counts went down, and again, the most common foods that we've discussed numerous times were milk and egg. In a review that we've discussed before, and a review of the literature through Figers evaluated 15 studies in children, and 2/3 of children had a positive skin test to at least one food. And again, the most common foods that were found to be abnormal, that had positive food testing, included peanut, egg, soy, and others shown here. There has been very few studies performed in adults to date. The positive skin tests to those food allergens have been noted to occur less frequently unless there's a history of a reaction to a food, and this may be an interesting point of discussion with our allergy colleagues too. Is this a different disease that occurs in adults, or is it the same disease that we see in children? Positive skin tests to environmental allergens were more common than positive skin tests. So again, suggesting the fact, are these different diseases? Have adults grown out of some of these diseases? So the benefits of this tailored diet is that it can be individualized to the patient and may be less restrictive than the 6-food elimination diet or one with elemental formulas. Difficulties are, and have been mentioned already by Dr. Atkins, of how do you identify what this diet might be, lack of standardization. This slide shows the studies that have been done to date looking at dietary restriction. And in fact, what you can see from these studies is you look at the response of patients who are clinically and histologically improved, and then the number of eosinophils after treatment. You can see that all of these have a high response and that the numbers of eosinophils have decreased. This goes back again to that question of how many are too many eosinophils, what's a threshold response, and I think we still don't have the exact answer to that. So nutritional management compliance and cost can be issues. The side effects relate to the potential inappropriate monitoring, and I think one of the important points is that nutritionists must be involved in the care of patients who have, if nutritional therapy is used. Now, when we move on to medical treatment, we talked about steroids, and corticosteroids can inhibit inflammation and also inhibit the migration of eosinophils into the sites, including the esophagus. So we talked about eosinophils coming from the blood vessel into the tissue site, and steroids are able to block the production of many of the molecules that may perpetuate this type of inflammatory response. But in truth, we don't know all their exact mechanisms in eosinophilic esophagitis. Systemic steroids, or the use of steroids in a liquid or a pill form that are at much higher doses, have been used in at least 2 studies and have been shown to be effective in reducing symptoms. They do have a use in some patients when urgent relief is required in the sense of severe dysphagia, severe failure to thrive, but in general, they're not something that we use as commonly, and long-term use has not been recommended. Now, topical steroids have been used and certainly are effective in many patients who have eosinophilic esophagitis. And it's important to remember that the use of this medicine is completely opposite of how you would use it for asthma. So instead of asthma, where we have a spacer, we have no spacer in the use of this medication in the treatment for eosinophilic esophagitis. Instead of spraying this and inhaling it, you spray it into the mouth and you don't inhale. And instead of rinsing the mouth out or trying to avoid some of those local potential for infections, we ask that the medication remain in the mouth so it can be swallowed over time. Now, the way that this was really first used was to try to eliminate the use of systemic steroids or liquid or pill forms of steroids and minimize some of the potential toxic side effects. The only side effect that we know of to date has been fungal infections. There's been 1 case report of the use of the arising of cataracts in this use of this, but overall we feel that it's reasonably a safe medication. Now here, again, we look at the impact of topical steroids. This is the numbers of eosinophils before and after treatment in at least 4 different studies. You can see that the numbers of eosinophils have decreased in all. And in this study, which was the only double-blind placebo-controlled study that has been performed, there was significant decrease. I think one of the important parts of that study was that they also identified patients that were non-responders to fluticasone. So what does that mean? Are those patients not responsive to steroids? Are they of this non-steroid responsive group, and maybe they're more allergic and require food elimination? We don't know that yet, and it's one of the areas that we really need to think about more clearly. So we know that they're effective in reducing emission. There are a number of different doses that can be used, including dosing for adults, and it can be used anywhere from 2 to 4 times a day. Our personal practice has been to use it twice a day. Now, another form of topical steroids has been tried and it was developed by the group in San Diego. And they had a very ingenious idea of trying to mix a liquid preparation of budesonide with a vehicle to bring it down into the esophagus. And they performed a retrospective study of 20 children who used this liquid preparation that was mixed with Splenda, mean age of 5.5 years, and they showed that 80% of those patients, in fact, went into clinical as well as histological remission. The results of this study have recently been, a prospective study have been published recently in Gastroenterology, which show very similar findings. Now, an important point that has been raised with patients here at the conference and was brought to mind by one of our families was, if you don't respond to liquid or pill form of steroid, if you don't respond to fluticasone, could you respond to another form of steroid? And in our experience, the answer is yes. And whether that reflects the preparation of the steroid or the way that that steroid is actually adhering to the esophagus, because none of these have been yet studied in a formal fashion, we don't know that. So it doesn't limit our practice to only use one form of steroid in the management of patients. I should say that there are ongoing studies now to look at different preparations of this budesonide that may in fact be helpful, and we'll look forward to the results of those studies. So corticosteroids, the potential side effects include bone demineralization, growth disturbance, cataracts, acne. We typically will monitor our patients for evidence of eye disease and monitor their bone density if we need to use these over time. We don't know what the quality of life, impact on quality of life is of these. And just looking at a comparison between steroids and nutrition, certainly both of them are durable. We feel that in patients they're very efficacious. I think trying to define who is going to respond to those different forms of therapy is going to be our next challenge. And because we don't have measures yet, good measures of quality of life, that we need to really wrestle with this and think about this in taking care of our patients. Now, as I showed you in the beginning, this is the life cycle of the eosinophil. Here is interleukin-5. I bring this up because it's been a matter of discussion, and this molecule has been studied extensively because we found that in studies from Cincinnati that IL-5 may, in basic mouse models of this disease, be very important in bringing eosinophils into the esophagus. So if you could target this, as was brought up earlier in one of the questions, and block the production of that molecule or block its actions, perhaps that may impact the disease. There has been a very recent study by Dr. Straumann in adult patients in which patients were randomized to receive either intravenous anti-interleukin-5 or a placebo for 8 weeks. This medication and treatment brought significant reduction in eosinophils and evidence of remodeling, but did not significantly impact symptoms. In this short study, there were no adverse side effects identified. This shows the data from that slide. I know it's very small, but this shows the eosinophils in a number of eosinophils in another study from Cincinnati that used anti-IL-5. In this study, it showed that there was a decline in eosinophils in all 4 of these patients over time. These patients did have an impact on their symptoms, but it was a limit of 4 studies in an open-label study. So we don't know today what the side effects are. It was brought up earlier. It's critical to think about that balance of the eosinophils that you need to maintain health, and the eosinophils are going to be damaging over time. So to close, I'd just like to show a suggested algorithm. We talked about a patient who has symptoms that we want to try to eliminate reflux disease. If we make the diagnosis of eosinophilic esophagitis, to think about both of these types of treatment, either steroids or dietary therapy. And then I think another area of discussion and of philosophical differences, or we need to think about the strategy to follow up our patients, is that how often do we retest, how often do we perform repeat endoscopies to monitor for disease activity. So treatment is really a balance. I think the relationship that you share with your physician needs to agree on some common endpoints and goals. Because as you can see, there are things that work, but we need to think about what those important goals and endpoints might be. This straddles that very important part of medicine, which is there's art of medicine and there's the science of medicine. And the science of medicine is driven by hypothesis-driven clinical and basic research, where we have data to base our decisions on, and the art of medicine is based on that clinical experience of seeing many patients with these diseases. So the take-home points are that treatment goals include eliminating symptoms and reducing complications. The nutritional management and corticosteroids are effective treatment, and deciding on who those patients are is an important part of practice, and decision-making is based on balancing risk and benefits. This requires long-term commitment, both from the patients as well as the physicians. I just want to note that the slides that I've shown to you were developed in conjunction with the North American Society of Pediatric GI Nutrition with support from AstraZeneca as well as Takeda Pharmaceuticals. And I thank you for your attention.